Thanks very much. Can everybody hear at the back? Can you hear? It's a little unusual holding this mic, but I feel like I'm going to sort of burst into song soon or something. So thank you very much for inviting me to the organizing committee. I looked at the agenda and it looks like a great list of speakers and topics and a really nice crowd. I'm a general pediatric hospitalist, as mentioned, from Sick Kids, and I would have to say that I went to university in Cape Town in South Africa, but after coming over to Canada, I spent the first 3 years of my professional career here as a family doctor, practicing in solo practice in rural Saskatchewan. So even though I'm now sort of in the ivory tower, I definitely have an appreciation for the difficulties and the challenges of being in primary care in family practice, and those 3 years were quite impactful on my career. Now, I'm not quite sure how to get my slides up here. Is there something specific that I need to do? So the topic that I was asked to talk on today is around the issue of overutilization of tests and therapies. So basically, what I called the talk was "Say Yes to the Less," making it easier to choose wisely. And I have to say, first of all, I have no disclosures. When you're trying to tell people to do less therapies, the pharmaceutical companies aren't banging your door down. So no disclosures at all. And I get the opportunity to speak about quite a few varying topics as a general pediatrician. I have to say this is one of the favorite areas that I like to talk about, because I do really feel it's relevant regardless of who you are and what you're doing in the healthcare spectrum. So my objectives for the next 35 minutes or so are to try and convince you why the topic of unnecessary care is really important in pediatrics, to help you understand some of the drivers of this. And then the second part of the talk, I want to talk a little bit about some strategies of how we can actually do better, and a little introduction to my take on choosing wisely. So whenever I'm talking, I do like to use a few cases as illustrative. And these cases are really, they're not profound at all. They're just incredibly mundane, quite honestly. But I'll loop back right at the end of the talk, and you'll see why I've picked out these three particular topics. So the first case is a classic 8-month-old with bronchiolitis. We're seeing plenty of these at the moment. In fact, I'm on ward service at the moment at Sick Kids. It's incredibly busy, and these kids with bronchiolitis are just starting to pour in. So typical case with bronchiolitis, saturating 90% in room air in the emergency department, probably going to land up being admitted. This is a no judgment zone. There's no judging. How many people would do respiratory viral testing? Just by a show of hands. No judging. Okay, it's interesting. I gave this talk at Montreal Children's Hospital a little while ago, used this case. Basically, 90% of the people there would do respiratory viral testing. So it is something that people do a lot of across Canada. Anyway, just to bring you into the picture in case you're not aware, in bronchiolitis, there are clinical practice guidelines from around the world, including Canada and the US, and respiratory viral testing in routine, typical cases of bronchiolitis is certainly not recommended. One of my fellows, Peter Gill, who's actually now on faculty at Sick Kids, wrote a really nice review of the evidence about respiratory viral testing for office-based practice, emerge-based practice, and hospital practice, and published it a couple of years ago, just in case anybody wants to read a little bit more about it. And one of the conclusions we reached, and this is true for everything that I'm going to talk about, is it's not good enough to do things just because we can do them. The second case that I want to talk about is more of a summertime thing. This is an 8-year-old who goes over on their ankle and comes into the clinic or the emergency department with a very swollen, tender ankle, not willing to weight bear. How many folks in the room would feel they would probably ask for an x-ray? So quite a large number. I would say when we looked at this at our practice at Sick Kids Emergency Department, the number was about 95%. And why is this important? So there is something called the low-risk ankle rule, which is the pediatric version of the Ottawa ankle rule. And Kathy Budis, who's one of our emerge docs at Sick Kids, actually is a world leader in this area of study, and basically has shown that if you perform the low-risk ankle rule, which takes less than a minute to do, and you're found to be at low risk, then if you don't do an X-ray, you will not miss a clinically significant fracture, and we'll come back to that. And then the third case I wanted to just mention to you was a very typical case of a 3-year-old who's coming in with acute ITP. Very well-looking child who comes in full of petechiae and bruises, and essentially when you do your CBC, you find that the platelet count is in the single digits, everything else looks good, and I've listed there a bunch of the different options in terms of treatment. At Sick Kids, when we started looking at resource stewardship, the answer was C. About 90 to 95% of children were being admitted for IVIG to treat ITP. And what's the issue here? The issue is that in typical ITP in children, about 80% of children have a very mild course and will get better within 6 months by themselves. What are we worried about? So we're worried about the possibility of bleeding, which is pretty rare, and the only significant bleed obviously would be into the head, and that's incredibly rare. Certainly in the 25 years I've practiced at Sick Kids, I haven't seen a case, but it's listed at about 1 in 1,000. Now we know if you get active treatment, whether it's IVIG or steroids, the platelet count will come up quicker than it would if you just left it to the natural history, but the actual impact on whether the child bleeds or not, or whether they go on to develop chronic ITP, it doesn't appear to actually impact that at all based on the studies. So all the clinical practice guidelines that look at ITP would suggest that if you fall into that 80% majority who don't have any active bleeding or just have a little bit of a mild nosebleed or something like that, then it would be very reasonable to observe the patient, and that has been published both in the US in 2011 and more recently through the Canadian Paediatric Society in Canada. But what actually happens, so if you look at data from the children's hospitals in the United States, about 95% of children with ITP get admitted and 80% of them get treated with IVIG, which is pretty similar to what we were doing at Sick Kids. And their guideline that I just quoted came out at 2011, and when they looked at practice before 2011 and after 2011, there was actually absolutely no difference. If you go across the ocean to the UK, you'll see that only 16% get active treatment, which is remarkably different from what's done in North America. And even though there's some crazy stuff going on with Brexit, I don't think that one would assume that there's more intracranial hemorrhage. Maybe there is, but I don't think so, based on the fact that they're treated very differently. So I'm going to come back to those cases, and it'll probably make sense at the end. So what's the what and the why of the problem? It seems increasingly clear, if you look at the literature over the last 5 or 10 years, that about 30% of the tests and the therapies that you and I order on our patients yesterday, next week, are probably unnecessary, do not add value, and in quite a few cases actually can cause some harm. Now, what does over-testing result in? I think you all know that, you know, I'm on ward service at the moment. I come in the morning, and I know that if a child's been admitted under me and they've had sort of 10 blood tests done, which most kids who come through the emerge will get a whole panel of tests, at least 1 or 2 of those will be falsely positive. In addition to that, there's the issue of incidentalomas, which are not false positives, they're actually true positives. So for example, I might do an ultrasound on a child because they have a urinary tract infection, and the radiology report says there's some sort of hyperechogenicity in the liver, you need to do further testing, suggest a CT scan. So there is actually something there. It is a true positive, but it's completely incidental to what you're worried about or what you're looking at, and almost invariably turns out to be unhelpful for the patient and just results in more testing. If anybody wants to read a really outstanding article on the issue of incidentalomas, in the New Yorker in 2015, Atul Gawande, who's an adult surgeon in Boston, an excellent writer, wrote this article called Overkill. I would highly recommend it. Makes very good reading. I'm not going to talk about overdiagnosis, but in pediatrics, like in adult medicine, we have a lot of overdiagnosis, things like hyperbilirubinemia in newborn babies, things like ADHD in school-age children, lots and lots of examples of overdiagnosis. And the result of all of these things is just the cycle of more and more and more testing. Now you might say, you know, we don't do a lot of tests on kids. You know, adults, yeah, sure, we can see we probably do more testing than we need. Well, the reality is we actually do way more to kids than we're supposed to. And this is just one example. It's a study that was published a few years ago from the US. It's looking at the top 40 children's hospitals in the United States. So this is the sort of pinnacle of pediatric practice in the United States. And what you're seeing on your left-hand side are some quality indicators in the most common problems. So asthma, bronchiolitis, pneumonia. These are the most common things kids are admitted to a hospital with. And that, I've circled the median hospital performance. So these are all things that these children should not be getting. And you can see that in the top 40 children's hospitals, many, many kids are getting things they probably shouldn't be getting. The only one in that list that you should be getting is the very bottom one, initial narrow-spectrum antibiotics for pneumonia. And you can see only 27% are actually getting what they should get. So that's not very good. The next thing you might say is, well, you know, that's an American problem. You know, medicine in the US is a business. There's an MRI machine on every street corner. So, you know, absolutely people do more testing than they should. Interestingly enough, when you look at Canadian data, and this is from Kai-High, looking at 8 adult choosing wisely, very common recommendations like imaging for low back pain, that kind of thing. Basically, they found the same number. About 30% of the tests and therapies were completely unnecessary and not indicated. I'm not going to dwell much on the dangers of unnecessary care. I would say that because children have their whole lives ahead of them, if you do an unnecessary CT scan, for example, in a young child, there is actually an appreciable increased risk of cancer over the course of their lifetime. To do some of the testing in children, you know, if you want a CT scan or an MRI or even any kind of sort of procedures, children generally will need a general anesthetic because they're not terribly cooperative. So there's all the risks of sedation and GAs. Of course, all the side effects. When you talk about unnecessary antibiotics, resistance to antibiotics is a huge problem in pediatrics. We talked a little bit about false positives, incidentalomas, all the anxiety that causes, and then, of course, the inconvenience to the family, the child, the discomfort, and you know, in terms of the actual healthcare system, there obviously are costs involved. For me personally, that's not the huge driver of looking at resource stewardship. It's much more about practicing good quality care, safe care, but cost is a big factor as well for various people. So it does beg the question, why do we do this? I think most people, or all people in the room, are probably well-trained. I think get up in the morning with the intention of really helping their patients, and yet we continue to do this. So these are some of the reasons in those bubbles. The issue of medical malpractice is much more of an issue in the United States. That usually comes up as the top one when you survey people about why they're doing things that are unnecessary. I don't think that's such a big issue in Canada, to be honest, based on the data, but some of those other things are. And I just wanted to introduce you, we don't have enough time to go into it in a lot of detail, but one or two concepts. The one is this issue of the therapeutic illusion. And there's a number of papers that have looked at this, and it's a well-proven sort of fact, I think, that both patients and physicians tend to overestimate the benefits of medical interventions and underestimate the harms. And it's interesting, when I am working at, say, kids, I'll often see families who are incredibly impressed by physicians who order about 20 or 30 different tests, as opposed to the physician who has really spent quite a lot of time on the history and the physical exam and realizes that the patient actually doesn't need any testing and actually knows what the diagnosis is. It's interesting that that person is perceived as perhaps less caring or less thorough, whereas the opposite is probably true. The other issue is this increasing discomfort with tolerating uncertainty. I don't know if it has to do with the era of the internet or Dr. Google, but everybody wants to see things in black and white. And I think healthcare clinicians are spending more and more time in front of computer screens looking at results and less time at the bedside talking to the patients and their families. And I think for those of us, and I think it's probably the entire room, who practice at the bedside, you realize that a lot of medicine is gray and there is no black and white. And this intolerance of uncertainty is what drives a lot of unnecessary testing. So I wanted to just talk very briefly about one of the potential solutions. There's no sort of magic bullet to this, but choosing wisely, I think, is an interesting concept that has arisen. And as you probably all know, it's a campaign to help people like us and patients start discussions like this around unnecessary tests and treatments and help us to make better decisions. And the sort of principle behind it, the concept, is that more is not always better. And I think you have to be careful because actually sometimes more is better. It's not like it's not always true, but often more is not always better. So what choosing wisely hasn't been around that long. It started in the United States about 7 years ago and moved up to Canada about 5 years ago as a partnership between the University of Toronto and the Canadian Medical Association. And they sort of started off by engaging all the national specialty associations to come up with these top 5 or top 10 lists of recommendations about tests and therapies that we should probably not be doing as often as we are. And if you look on the website, it's actually a lovely website, choosingwiselycanada.ca. There's actually over 300 recommendations from all the specialties, including family medicine. One of the things that's really encouraging is that other groups like nursing, pharmacy, dentistry have all got on the bandwagon and created the lists. And in pediatrics, the American Academy of Pediatrics was one of the original group in 2012 that came out with a list. I've ringed a few that are pretty relevant to primary care practice. So number 1 and 2, these will not be things that are news to you. I mean, they're obviously very familiar. Number 7 and 8 are also, I think, things that affect office-based practice. And then the Canadian Paediatric Society a couple of years ago also came up with their top 5 list, and some of them will look very familiar. In fact, their number 1, 2, and 5 are the same as recommendations on the American list. And then they added in number 3, don't administer psychostimulant meds to preschool children with ADD, but rather offer parent-administered behavioral therapy. It's more effective and it's less likely to cause side effects. And number 4, I think we all know that you shouldn't treat pharyngitis without doing a throat swab, which shows that it's positive for strep. But the CPS went a little bit further and said, do not do a throat swab if the child has viral symptoms, because you're much more likely to have a viral pharyngitis, and because of the reasonably high strep carriage rate, even if you have a viral pharyngitis, you are going to get a lot of positive strep tests. So that's what they came up with. The problem with this is these lists actually don't work. It doesn't really make any difference. So this is just one paper that I've quoted, but it's often quoted from the US looking at national insurance data for 7 choosing wisely recommendations. And these are the most well-accepted things like related to low back pain and imaging and things like that. And essentially what they found is drawing up these lists and circulating these lists does not appear to have much impact on people's practice. And this probably shouldn't surprise us because it's not that different from clinical practice guidelines. None of these things that we see on the Choosing Wisely lists haven't appeared in many different clinical practice guidelines before. So it's not really good enough just to make the list. That's kind of the straightforward part. We have to do a little bit more. And I wanted to spend the second part of the talk just quickly reviewing a couple of ideas where I think there is the possibility of making some impact and improving things. So the one reason for optimism is this happy, smiley group of people. These are medical students from the 17 med schools across Canada, and Choosing Wisely Canada gets them together under the auspices of something called Students Advocating for Resource Stewardship, or STARS. And they actually came up with their own top 5 list for Choosing Wisely. And it's not content specific, it's more related to the approach. And you can learn a few things from this Canadian medical student Choosing Wisely list. Number one is we probably don't teach math that well because there's actually 6 things on their top 5 list. But in a more serious vein, if you look at those suggestions, we, as their role models, as their supervisors, as their teachers, if we were able to actually empower them to do some of the things that they're suggesting, I think we would go a long way towards improving resource stewardship. The other encouraging thing is that the regulatory bodies, such as the Royal College, as well as the College of Family Medicine, have started to develop toolkits to help us to teach ourselves and teach our trainees about resource stewardship. And there's some great toolkits, for example, how to speak to patients or families about not doing unnecessary tests and therapies, which is a really difficult thing. And then there's some very, very practical toolkits that Choosing Wisely make available, and I'm sure many of you have probably seen some of these and maybe even have them in your office. Just an example would be the using antibiotics wisely. And I think some of them actually might even be on the tables, some examples. As you probably know, probably half of the antibiotics we use for respiratory infections in primary care are unnecessary, so there's a lot of room for improvement. And I found this interesting. This was a survey that Choosing Wisely Canada did just this year. And, you know, we think that people have got the message about antibiotics not being effective for colds and flus and viruses. But I think what you can see from this survey is that probably about half of people who are surveyed do think that antibiotics are effective against viruses and colds and flu. And actually about 30% of them do expect an antibiotic when they come into your offices. So Choosing Wisely has provided a lot of material. I think one of the stumbling blocks to really doing this is, I think we all intuitively know it's a good idea, but it's incredibly laborious and time-consuming to try and convince a family to understand some of these concepts. So some of these materials, I think, are useful as a way of sort of trying to prime families for the message. They've actually translated these things into 17 languages, which in Toronto is a good idea because just about everybody speaks a different language. And I really like some of these practical tools. And again, I think there might be some of them available somewhere outside, but particularly these 2 things. The one thing, when people come into the office, they want to leave with something. They want to go home with something in their hands, and that's often why we end up giving them a prescription. So the viral prescription pad's a great thing because it does give you the ability to sort of educate them a little bit, but it also gives you the ability to prescribe stuff for them. So you might be prescribing rest or fluids or acetaminophen or nasal saline, but it actually allows them to leave your office with a prescription in hand. And it's not just telling them not to do stuff, it's actually being positive. There's also the delayed prescription pad, which basically I think is a really good idea as well. It gives you the opportunity to say, you might need an antibiotic, but you certainly don't need it for the next 24, 48 hours, and it gives you an opportunity to tell them which what the indications would be to actually fill the prescription, and it's actually been shown to be helpful. I just wanted to finish off quickly by talking a little bit about the work that I've done with a team of people at Sick Kids. Obviously, most people here do not work in a tertiary care hospital, so you don't have access to the resources we have. But the concept and the principles are actually extrapolatable to a clinic, to a community center or hospital as well. So we wanted to do some work in resource stewardship, but to be honest, the lists mainly reflect office-based practice and not really a tertiary quaternary practice in pediatrics anyway. So we went out to some of our stakeholders in the pharmacy and diagnostic imaging and labs, and we said, what do we do really badly at Sick Kids? And quite frankly, we do quite a few things not so well. So there was no shortage of suggestions. And they came out with a whole lot of suggestions of things that we were doing way too often and unnecessarily. And we landed up with about 15 suggestions. We sent it out to all of our full-time pediatricians, all of our residents, and we asked them in a sort of anonymous survey to score the ones that they felt were most important for us to kind of start to improve our practice. And we landed up with these 5 things on our first list in 2016. We've gone on to do a second and third list as well. As I mentioned, creating the list is sort of the easy part, it's the fun part, but quite frankly, it's not terribly impactful. Implementation is kind of where the real problem is. And I like this slide from Choosing Wisely because it kind of gives you a sense of what your options are in terms of trying to get the changing practice. So most people gravitate towards the left side, education, a little bit of what I'm doing here, awareness, talking to clinicians and patients. It's a really important part, but it's a bottomless pit, and certainly in a teaching hospital, you can never stop with the educating. The actual money is on the right-hand side. It's basically on the hard coding side. So making it easy for people to do the right thing and making it quite hard to do the wrong thing. So if you have an EMR or you have directives or anything like that, embedding the recommendations into those things. And I'm going to just finish up with the 3 cases and just give you a sense of how we turned around our practice, because I'm hoping that maybe some of the principles might be applicable to your own practices, or it might give you some ideas about how you could actually change your practice. So we wanted to cut back on the number of respiratory viral testing that was being done in our emergency department because, quite frankly, it wasn't indicated, and it's uncomfortable for the patients. It upsets the children, it upsets the family, wastes the nurse's time, it wastes the lab time. There's quite a lot of cost involved as well. So what we did was we basically embedded it into our order sets, so you couldn't actually order these things unless you actually said what the indication was. And a group got together, came up with a few appropriate indications. For example, if you, in the first 2 months of life, or you're immunocompromised, and having an actual viral diagnosis might allow you to not do a whole lot of other testing, or might make the decision between antibiotics or not. Obviously, that's reasonable. On the other hand, if you're just trying to confirm that you have bronchiolitis or a viral pneumonia or something, that's actually not really appropriate. The other thing I just wanted to show you was, if you look at any group practice, so this particular slide, if you look at the x-axis, each number is an emerge physician at the Sick Kids Emergency Department. The y-axis is the number of rapid flu tests that they ordered in the flu season in 2016. And they're all seeing the exact same patients, and it's been smoothed out, so it's the same amount of clinical exposure time. And what you can see is, on the right-hand side, there's a group of people who did 70 rapid flu tests, and the majority of people did 10 or less. So what the person who was championing this project did was basically sent the results back to each individual, said, this is how many swabs you've done, this is the average for our group, this is really what we're aiming for in terms of our goals. Didn't tell them what to do, basically just fed back the results. And behavioral psychologists will tell you that that is one of the most effective ways of changing behavior. We're all type A, we're all incredibly competitive, nobody wants to be on the wrong side of the bell curve. So audit and feedback, if you can measure what you're actually doing, is incredibly impactful, and it applies to things like antibiotic prescriptions as well. And just to prove that it does work, it's a complicated chart, but the bottom line is in 2016, in the first season that we introduced our changes, there was an 85% reduction in the number of viral tests sent, and that was sustained in the next 2 years, and that's really the take-home point. And then just the example I gave you of the kids coming in with ankle injuries. It's a bit sobering to think that we, in our own emergency department, have one of the world leaders in this area of research who has done randomized controlled trials in our emergency department, published in the Lancet, the highest impact journals, and is a highly respected, incredibly sort of well-liked clinician in our emergency department. And yet 95% of kids were still getting x-rays, even though that's contrary to what she had proven. So it kind of makes you realize just how difficult it is to convert research findings into actual practice. So the good news was that our emergency room fellows took this on as a quality improvement project, and the actual sort of, I would say, the enabling factor here was on the x-ray form. When you ordered an ankle x-ray, we added a line which said, have you done the low-risk ankle rule? Yes or no? Are you low risk? And I think that was probably the single most biggest reason why we were able to drop this from 90% to 50%, which is where it should sit. The other thing that we did, which is really important, was we created a Dear Parent letter that was given to parents in the waiting room to say, if your child meets the criteria for low risk, then the good news is they won't need an x-ray. So you won't have to waste your time and you won't get any unnecessary radiation. So they were already primed to know, and you didn't have to spend sort of 10 minutes convincing them why an x-ray wasn't necessary. So those were probably the two big things that helped us to turn this around. I should also say, when you're doing this work, you do need to look at what we call balancing factors. So you have to make sure you're not missing any fractures. The good news is we haven't missed any yet. And then the last one was this issue around using IVIG for every child with ITP, which, as I said, the evidence shows that that's not the case. This one's a little bit more complicated because there's no real right or wrong. There are some situations, for example, if it's a very rambunctious toddler who's bumping their head every 5 minutes and the family lives 3 hours from medical care and they're incredibly anxious, then actually IVIG might be the best treatment for that family. But for other families, observation's absolutely fine. So for this, we actually developed what we call a shared decision-making script, where all the physicians who were going to go in and see these families basically had a sort of prepared script offering what the different options were. The family got a little package which explained what the pros and cons of active treatment versus observation were. And essentially, we went from 90% getting IVIG. At the moment, we're probably at about 20-30%, which is appropriate. So what are my take-home points? I really want you to think about the fact that when we all leave this room and we go back to our practice, about 30% of what we do probably doesn't add value, and quite a lot of it actually causes harm. I think it's quite easy for us. In pediatrics, we blame the families. In hospital practice, we blame the hospital administrators. We like to blame the government. We actually blame everybody. But the reality is, we are the people who are ordering the tests, and we are the people that are prescribing the therapies. So we need to own a significant piece of this. I think we really do. Choosing wisely, I don't think it's a silver bullet. I don't think it's going to be the answer to all of our problems, but I do think it's a great opportunity for some increased dialogue and action. a lot of it boils down to critical thinking and a willingness to kind of think through these problems as opposed to knee-jerk sending off a whole lot of tests that might lead you down the wrong way. I do think if you want to change culture, targeting trainees and trying to, in fact, the trainees are way ahead of us in terms of wanting to save the environment and save resources as well. So changing the culture is important. And then I hope I showed you that if you're interested, there are ways of locally taking some of these ideas, looking at what you do really badly, trying to measure it, and then using some of the implementation principles to actually not just make a list of things to do, but to actually implement that list and be able to look at that. So I think I'll stop there. I apologize if I went a few minutes over, but I'm happy to take any questions.